The House Health Policy Committee will come to order, and I did want to outline that we are sitting room only. So there are overflow rooms in 502 and 521 down the hall with TVs set up so that you can watch. Would the clerk please take attendance?
Chair Rogers.
Here.
Representatives Whitsett.
Here.
Carter.
Here.
Hadsma. Neely.
Here.
Glanville.
Present.
Kafia. Conlon.
Here.
Farhat.
Here.
Fitzgerald.
Here.
Miller.
Here.
Reingans. Vanderwall.
Present.
Filler.
Yes.
Mueller.
Here.
Van Workum.
Here.
Roth.
Here.
Schmaltz.
Here.
Thompson.
Present.
Madam Chair, you have 17 members present. You do have a quorum.
Thank you. Representative Miller moves to approve the minutes from our meeting on September 6th. Seeing no objection, minutes are approved. Today we will be voting on SB 280 and considering an H1 substitute for SB 281 before voting to report SB 281. We will then hear testimony on House Bills 4949 through 4959, an 11 bill package known as the Reproductive Health Act. I think I have a card on just 281. Okay. Representative Conlon moves to report SB 280 with recommendation. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Whitsett.
Yes.
Carter.
Yes.
Hadsma.
Yes.
Neely.
Yes.
Glanville.
Yes.
Kafia. Conlon.
Yes.
Farhat.
Yes.
Fitzgerald.
Yes.
We're going to pause a second and go at ease. Call the chair.
For this one, and then you can go to East.
No, we're just going to reconsider it later. Health policy will resume. Clerk, please resume with the call of the vote.
Report Senate Bill 280 with recommendation. The last member voted was Representative Fitzgerald. Representative Miller.
Yes.
Reingans. Vanderwall.
Present. Or yes. Excuse me.
Filler.
Yes.
Mueller.
Yes.
Yes or pass?
Yes.
Van Workum.
Yes.
Roth.
Yes.
Schmaltz.
Yes.
Thompson.
Yes.
Madam Chair, you have 17 members.
Clerk, could you go back since we had two members join us to Representative Reingans and Kafia, please?
Representative Kafia.
Present.
We're voting yes or no on SB 280.
Yes.
And Representative Reingans.
Yes on 280.
Thank you.
Madam Chair, you have 19 yeas, 0 nays, and 0 pass. Senate Bill 280 is reported with recommendation.
Moving on to Senate Bill 281, we have an H1 substitute with some technical changes. And to speak to the substitute, we have Chris Young, Chief of Staff for Senator Singh, Neema Katabi from the Michigan Dental Association, and Joseph Sullivan, Legislative Liaison Manager for the Department of Insurance and Financial Services. If you'd all like to come up and join us, we welcome you, and you can begin whenever you're ready.
Thank you, Madam Chair, members. A lot of firepower here to discuss some language that's mostly stylistic, but I'll let Joseph Sullivan from DIFS address it, if that's okay.
Thanks, Chris. Again, Joseph Sullivan, Legislative Liaison Manager for the Michigan Department of Insurance and Financial Services. Just to reiterate, DIF supports this bill because we believe the transparency requirements will benefit all parties involved, including consumers and providers, and will bring Michigan in line with other states that have adopted similar standards. So I can give an overview of what the H1 substitute includes. Essentially, it is cleanup language for technical and grammatical issues. The sub also correctly places the language in Chapter 20 of the Insurance Code, an issue that was previously addressed in the S1 version from introduction that had incorrectly placed the language in Chapter 34 of the Insurance Code. So that was rectified previously, and this makes 5 technical changes. On page 2, there's just a grammatical change. On page 3, the language was changed from in existence as of the date of the contract is entered into or renewed. In existence was changed to that would have access to the dental services or contractual discounts of the provider network contract. The explanation is in existence was vague, so we adapted the language from the definition of third party on page 5. Additionally, page 4 changed a list of contracting entities affiliates must be made available. Made available was changed made available to readily accessible. To eliminate any ambiguity there. Page 4, such as, was changed to including. And then also on page 4, there was a list of regulated entities and dental insurance company, dental service corporation, and dental plan organization were listed. Those are not defined terms, so that was changed to or an entity authorized to provide dental benefits. And really that's just to ensure consistency and make sure that everything is captured there. So really that's it. I'm happy to answer any questions.
If we could just go through everyone's testimony and then we'll hold questions for the end in the interest of time. Thank you.
Nima Katabai with the Michigan Dental Association. Joe covered the changes that are there. The Michigan Dental Association appreciates the department's support and help with this bill. It was a complex issue, so we were working on a lot of this language until the last minute to make sure it works, and again, appreciate their work on this.
Any wrap up, Chris?
Just noting that this language from DIFS partnered with Michigan Dental Association that we've also shared with all the stakeholders that had previously expressed their position in the committee last week and that had no bearing on their position on the bill too. So,
Thank you. Do members have questions? Seeing none, will the clerk please take the vote? Sorry, I should specify. First, moving on to H1 substitute for Senate Bill 281, Representative Reingans moves to adopt. Madam Clerk, please take the vote.
To adopt the substitute, Chair Rogers.
Yes.
Representatives Witset,
Yes.
Carter,
Yes.
Hadsma,
Yes.
Neely,
Yes.
Glanville,
Yes.
Kafia,
Yes.
Conlon,
Yes.
Farhat,
Yes.
Fitzgerald,
Yes.
Miller,
Yes.
Reingans,
Yes.
Vanderwall,
Yes.
Filler,
Yes.
Mueller,
Yes.
Van Workum,
Yes.
Roth,
Yes.
Schmaltz,
Yes.
Thompson.
Yes.
Madam Chair, you have 19 yeas, 0 nays, and 0 pass. The substitute is adopted.
Thank you for all this bipartisanship today, ladies and gentlemen. Representative Fitzgerald moves to report SB 281 with recommendation as substitute H1. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Witset.
Yes.
Carter.
Yes.
Hadsma.
Yes.
Neely.
Yes.
Glanville.
Yes.
Kafia.
Yes.
Conlon.
Yes.
Farhat.
Yes.
Fitzgerald.
Yes.
Miller.
Yes.
Reingans.
Yes.
Vanderwall.
Yes.
Filler.
Yes.
Mueller.
Yes.
Van Workum.
Yes.
Roth.
Yes.
Schmaltz.
Yes.
Thompson.
Yes.
Madam Chair, you have 19 yeas, 0 nays, and 0 pass. Senate Bill 281 is reported with recommendation as substitute H1.
Motion's passed. Thank you. And thank you for your testimony. Moving on, we will now hear testimony on the Reproductive Health Act, House Bills 4949 through 4959. This legislation ensures that Michigan laws reflect the Reproductive Freedom for All Amendment to Michigan's Constitution adopted by the people of our state. We have a long list of groups and individuals wishing to testify, so I'm asking that we hold questions until the very end of after both sides have given testimony. It is my intention for this meeting and this testimony to be civil and respectful. That means, as a reminder, to direct questions to the chair and don't talk over one another. I ask that comments and questions remain germane to the specific bills before us today. We will hear from Representative Pahutsky if she wants to make her way forward, and then Dr. Sarah Wallet with Planned Parenthood of Michigan, Dr. Haley Chrisman with the American College of Obstetrics and Gynecologists, Dr. Sharita Roque from the Western Michigan University Homer Stryker MD School of Medicine, Amanda Major, Dr. Rob Davidson, Executive Director of Committee to Protect Healthcare, and then speaking jointly, we will hear from Dr. Michelle Monticello, Dr. Kathy Stark, Tom Hickson representing the Michigan Catholic Conference, and Eileen McNeil with Citizens for Traditional Values. We will then hear from Genevieve Marnin from Right to Life of Michigan. Finally, we will hear from Lisa Harris from University of Michigan. To start us off, we have Representative Lori Pahutsky to speak to the whole package. Thank you so much for your hard work in joining us today.
Thank you, Madam Chair and members of the committee. I intend to be very brief. When these laws were put into place, there was a focus on what politicians had to say. And the fact of the matter is, this is a matter for healthcare. So we have both doctors and patients here, and that is the most important thing. We are not going to repeat the mistakes of the past. So the purpose of this bill package is to make sure that the constitutional right that was enshrined in November's election is accessible and safe and affordable to everybody in the state. A right is not a right if you cannot access it. So this package seeks to repeal medically unnecessary laws that apply only to abortion. No other form of healthcare in the state of Michigan, no other healthcare facilities face these level or this type of these types of restrictions. There is nothing in this package that would prohibit typical regulation and oversight of healthcare facilities, including abortion facilities. This is just about removing laws that were intended strictly to reduce access solely to abortion care. So I know that the chair said that we are going to save questions for the end. I will be here, I will be available, but for the sake of time and making sure that the people who are more appropriate to speak to this matter are able to do so, that is all I have at this time.
Thank you so much, Representative Pahutsky. Next up, we have Dr. Sarah Wallet, Chief Medical Operating Officer for Planned Parenthood of Michigan. Thank you, Dr. Wallet.
My name is Dr. Sarah Wallet. As you heard, I'm the Chief Medical Operating Officer for Planned Parenthood of Michigan. I'm a board-certified obstetrician and gynecologist with subspecialty training in complex family planning. Thank you for inviting me here today to testify in support of the Reproductive Health Act. Planned Parenthood of Michigan cares for approximately 1/3 of all patients seeking abortion care in Michigan. And as a dedicated provider of sexual and reproductive health care, we and our patients face unnecessary barriers, stigma, and shame under current Michigan law. It is this perspective that I want to share with you today to underscore why it's so urgent that we pass the Reproductive Health Act. Last year, Michigan voters overwhelmingly supported Proposal 3, which enshrined the right to reproductive freedom into our state constitution. Unfortunately, despite this significant step forward, our law books are still riddled with harmful and medically unnecessary laws that restrict access to essential health care and restrict my ability to provide the best care possible to my patients. These laws include medically unnecessary delays to care and arbitrary waiting periods. There are barriers to funding for abortion providers, limits on insurance coverage, and targeted regulations that were explicitly designed by politicians, not medical experts, to make it difficult and financially burdensome for patients to access the services that they desperately need, and for abortion providers like Planned Parenthood to operate health centers and provide care to patients in rural and underserved areas. Despite claims by abortion opponents, none of these laws are necessary. None of these laws are evidence-based, and none of these laws enhance patient safety. In fact, these laws endanger my ability to care for my patients every single day. I recently saw a patient who flew to Michigan from Texas for an appointment at one of our health centers. She knew that Michigan was a haven state for abortion access, but she did not know about the legally required 24-hour delay before we could treat her. This patient had planned a one-day trip, a morning flight to Michigan and an evening flight back home to Texas. She didn't bring luggage. She hadn't budgeted for a hotel. She hadn't planned extra days off work. But she learned that if she returned home to Texas that evening as planned, her only option would be to continue a pregnancy against her will. So our staff jumped into action and secured the logistical and financial support she needed so that in the end she was able to stay just long enough to meet Michigan's mandated delay, get the care she needed, and safely return home. I could tell you countless stories like this, of patients who've flown in from faraway states to see us, but also stories of Michiganders who, because they live in rural areas of our state, are forced to drive 7 hours to a health center and back for a single appointment. Or patients who make insignificant clerical errors on their state consent forms and are forced to reschedule their appointments. Patients who have health insurance, but their insurance can't or won't cover abortion care because of these laws still in our books. We recently saw an insured patient who fell into this trap. On the day of her appointment, she came into our health center visibly exhausted, and when we asked if she was okay, she told us she had gotten less than 1 hour's sleep the night before, because she had realized just hours before her appointment that she was $49 short of the estimated cost we had provided. She was worried that we wouldn't see her if she didn't have the full fee in hand by morning. She didn't want to have to cancel and try to make another appointment, so instead she stayed up all night to drive DoorDash, over $49. Let me be clear, one-size-fits-all approaches do not belong in medicine. But because Michigan politicians believe they know better than doctors, I had to look a patient in the eye last month and confirm that 24 hours prior to her appointment, she had received and reviewed state-mandated information, informing her that she had other options for her and encouraging her to consider prenatal care and parenting. This was despite both of us knowing that she was not there because she didn't want to continue her pregnancy. She very much did, but because she knew it wasn't possible. Her pregnancy had an anomaly incompatible with life, and to her, abortion was her only option. She asked me with tears in her eyes why I had forced her to look at information that wasn't relevant to her, that only made this harder for her and her family, going through this heartbreak. I could only reply, because Michigan law requires me to. Patients shouldn't have to suffer like this, to overcome deeply cruel and unnecessary barriers just to access essential sexual and reproductive health care in Michigan. We need to pass the Reproductive Health Act so these stories become a thing of the past, and Michigan can finally fully deliver on our promise to protect reproductive freedom once and for all. These restrictions and unnecessary regulations prevent me from providing patient-centered care to my patients every day. I have never once been able to provide care to my patients that is solely focused on them. Because with every patient, I have to make sure I'm following state laws that cause my patients harm. And it's overwhelming when I think about it because I've been forced to do this for so long, it can start to feel normal. But it shouldn't be. This isn't okay, and I'm tired of having to pretend like it is. I take my commitment to my work very seriously, so seriously that I sued the state of Michigan last year to protect my patients. But when I filed that lawsuit to block Michigan's 1931 trigger law from taking effect, that was just to protect the status quo, just to allow me to continue providing abortion care at all, so that my patients wouldn't have to go without and I wouldn't have to go to jail. We need to do better. We have to do better. Every single day since November 8th, 2022, when Michiganders overwhelmingly voted for reproductive freedom, my patients, as well as providers, have been waiting for legislators to make the promise of Proposal 3 a reality. We can't wait any longer to pass the Reproductive Health Act. Because when it is law, I will finally be able to provide true patient-centered care to everyone who comes through our doors. We'll finally treat abortion like the health care it is. And we'll finally be able to remove the stigma, shame, and harm these laws cause every single day to real Michiganders. Today, I'm proud to be a Michigander, a doctor, and an abortion provider fighting for my patients, their futures, their families, and all of our communities. Thank you to the bill's sponsors for moving this urgent legislation forward. And thank you again for inviting me to speak.
Thank you, Dr. Wallet. Joining us next is Dr. Haley Chrisman with the American College of Obstetrics and Gynecologists, and Dr. Sharita Roque, a physician from Western Michigan University Homer Stryker MD School of Medicine. Welcome and begin whenever you are ready.
Thank you, Chair and Policy Committee. I'm Dr. Hallie Chrisman. I sit before you as a Michigander raised in Midland, a board-certified obstetrician-gynecologist based in Dexter, a mother, and, as is probably quite obvious, a pregnant person. I'm also representing the American College of Obstetrics and Gynecology, or ACOG. ACOG is the governing body and the source for clinical standards of care for the specialty of obstetrics and gynecology across the United States. ACOG is a nonpartisan organization representing more than 950 OBGYNs in the state of Michigan and more than 60,000 OBGYNs nationwide. Last year, I felt incredible relief for my patients when Prop 3 passed. But I also knew that as a physician who provides pregnancy and abortion care, that my work was far from over as an advocate for my patients. Anti-abortion politicians have spent decades passing laws in Michigan that make abortion care harder to access, criminalize healthcare providers like me for providing medical care, and interfere with the patient-clinician relationship, including my ability to provide care aligned with the best medical evidence and standards. The majority of the bills in the RHA package will repeal old anti-abortion laws that were designed to restrict my patients' access to care. These laws were enacted under the guise of safety, and they imply that abortion care is dangerous and thus requires special scrutiny or regulation. However, in reality, abortion care is extremely safe. And none of the laws the RHA repeals have ever been shown to make abortion care safer. For example, in relation to the repeal of the outpatient surgical facility requirement, a 2018 National Academies of Sciences, Engineering, and Medicine report found there is no evidence that performing procedural abortions in an ambulatory surgical center increases safety of the procedure compared to procedures in the clinic setting. For context, the risk of death associated with childbirth is 14 times higher than with abortion care. Mortality rates are higher for colonoscopies and adult tonsillectomies compared to abortion care. Moreover, the laws repealed in this package were written in the time of Roe v. Wade, when in theory all Americans had the right to abortion care. Now, in a post-Dobbs world, without the protections of Roe, these antiquated laws are being aggressively used by prosecutors who are anti-abortion to restrict access and intimidate providers. We are witnessing this in real time as patients from other states travel across state lines for time-sensitive care, as OBGYNs leave states where comprehensive reproductive health care is criminalized, and as OBGYN resident recruitment is down in states restricting abortion care, which worsens maternity care deserts that are painfully worsening maternal mortality and disproportionately impact people of color. We simply cannot jeopardize the care of Michiganders and the loss of healthcare providers by leaving these laws on the books, or by waiting for each individual restriction to be brought to court for their constitutionality to be scrutinized. In order to ensure Michiganders actually have access to the abortion care that Prop 3 made legal, and that healthcare providers can focus on providing evidence-based care without fear of criminalization, we need to pass the RHA. Some may wonder why this is necessary in the wake of Prop 3. As it stands, even with Prop 3 in place, I see patients every day turned away from clinic because the arbitrary timestamp on their state-required 24-hour consent form is not yet valid. I see patients traveling extreme distances from northern Michigan for care because restrictions make it too hard for their local healthcare provider to provide abortion care. I see patients working to make ends meet delay while they try to scrape together the funds to pay for abortion care, to pay for health care that their private or public insurance, their health insurance, is banned from covering. And time I would rather spend focused on the best possible care for my patients, or frankly, on my growing family, I spend worrying about criminal penalties if arbitrary reporting forms don't make it to the state in the 7-day time frame, or if vague procedural bans with inflammatory political language are used to attack the high-quality medical care that I strive to provide each unique patient I care for using my years of medical training and judgment. I urge this committee to pass the RHA, and in doing so, to roll back decades of inflammatory, stigmatizing, criminalizing, medically unnecessary Michigan laws that continue to hinder my ability to provide abortion care that is best aligned with medical evidence and standards. It is incredibly uplifting as a healthcare provider to see our state have such a powerful opportunity to get politicians out of our exam rooms, to restore patient-clinician relationships by removing unnecessary legislative interference, and to stop siloing, criminalizing and stigmatizing abortion care differently than all other health care. On behalf of my patients, ACOG, and future generations of Michiganders, I thank you for your work, ask you to move the RHA forward, and would be happy to answer questions at the end of the session.
Thank you. Dr. Roque?
Hello, my name is Dr. Sharita Roque, and I am an assistant professor in obstetrics and gynecology at Western Michigan University, Homer Stryker MD School of Medicine. But today, I am here in a personal capacity, representing myself as a doctor who provides abortions, and a woman of faith. The only place I've ever given testimony before is in church, but I felt compelled to speak today, not just for myself, but on behalf of my patients whose voices may not otherwise be heard. I'm a native Midwesterner, but a relatively new Michigander. I was raised in Indiana, got my undergraduate degree in Tennessee, and attended medical school in Ohio. While in Ohio, I completed residency and later did a complex family planning fellowship at Johns Hopkins University. I loved my community. I loved my patients. I loved my hospital and my coworkers. And I was looking forward to continuing my career in Ohio. But that was in June 2022, and my timing couldn't have been worse. Because that was the same month the United States Supreme Court overturned Roe v. Wade, ended federal protection for abortion, and threw the nation's public health infrastructure into crisis. My coworkers were blunt. They told me to leave Ohio. If I wanted to practice the kind of medicine I was passionate about, Ohio was going to be a difficult place to work, since anti-abortion politicians controlled the state legislature and were likely to ban abortion as quickly and as fully as possible. So I took their advice and made the difficult decision to leave. I left because I wanted to use my skills to help as many people as possible. I wanted to be able to care for my patients fully. So when we talk about the impacts of the Supreme Court's decision last summer, remember, it's not just patients who are being forced to flee their home state. In a post-Roe world, it's providers too. While I'm grateful for the opportunity to live and work in a state with strong leadership and voters who overwhelmingly supported Prop 3 last fall, I'm here today to echo the other providers and advocates testifying alongside me and to underscore how urgent it is that we pass the Reproductive Health Act for Michigan. When passed, the Reproductive Health Act will remove unnecessary, outdated, and harmful laws from Michigan's books and finally make it possible for me and other dedicated providers like me to provide the highest quality patient-centered care to all who rely on us. Sorry. Recently, a physician who specializes in high-risk obstetrics referred a patient to me with heart failure. The patient had developed peripartum cardiomyopathy following her last pregnancy, which is a condition that requires specialist care and multiple daily medications. As soon as she discovered she was pregnant, her specialist referred her to a maternal fetal medicine specialist who estimated her chances of dying in her current pregnancy at 20 to 27%. Not wanting to risk her life or leave the young child she already had without a mother, she decided to get an abortion. But by the time she finally got to me, she was 13 weeks pregnant and the clock was ticking. Due to her high-risk health status, we expedited her care, scheduled her appointment for a couple of days later. However, there were barriers she didn't expect. In Michigan, patients are legally required to physically print out a form at least 24 hours prior to their appointment, and she didn't have access to a printer. This led to her appointment needing to be rescheduled. During that time, her cardiac status became even higher risk, and it was evident that she would need a higher level of care in a hospital setting. This meant that the cost would be much, much higher, over $10,000. And since her insurance was legally prohibited from covering abortion care, she anticipated she would have to incur significant medical debt. In the end, she suffered a 5-week delay from the first day I saw her to when her procedure was finally completed. The delay was entirely unnecessary and entirely caused by the unconstitutional laws targeting abortion that are still in effect in Michigan. The 24-hour mandated delay in care, the required consent form, the restrictions on insurance coverage, just to name a few. Often after an abortion, my patients will thank me for caring for them. But every time they thank me, it feels bittersweet. I'm glad to be there for them and to provide the services they need. But in those thank yous, you also hear the struggles and the obstacles they had to overcome just to get into my office in the first place. Because theoretically, all of my patients have a constitutional right to reproductive freedom, but until we pass the RHA and remove these cruel and unnecessary laws from our law books, that right, for far too many, will remain out of reach. And patients like mine will continue to pay the price. As I mentioned earlier, I'm a woman of faith, and it is my Christian beliefs that help drive me to do this work. Because practicing medicine is compassion in action. I'm grateful for the opportunity to be there for my patients when they need me the most, to answer their questions, to hear their concerns, and to serve them in their times of need. Sometimes when patients find out that I'm Christian, they ask me to pray with them. I always do so. Far too many people are conflicted and filled with shame because the discourse around abortion is so violent, dehumanizing, and isolating, while our actual lived lives are complex and nuanced. I look forward to a day when everyone is finally able to make decisions about their lives and their bodies without interference and able to access the health care they need when they need it and without delay. Thank you again for having me today, and thank you for moving the Reproductive Health Act forward so that all Michiganders can finally have true reproductive freedom.
Thank you, Dr. Chrisman and Dr. Roque, for your testimony. With a personal experience in struggling to obtain medically necessary health care as a result of the laws these bills repeal, we have Amanda Major. If you'd like to come forward. Welcome, Ms. Major, and begin whenever you are ready.
Good morning, Chairperson Rogers and members of the Health Policy Committee. Thank you for having me here today. My name is Amanda Major, and I live in rural Northwest Michigan with my husband and our 2 young children. My husband and I were expecting what we hoped would be our second child in 2017 when a routine ultrasound at 20 weeks revealed potential problems. These problems quickly opened my eyes to a whole host of Michigan anti-abortion laws that would lead my family down a path of anguish and stress, serve no medical purpose, and interfere with our ability to make a decision that was best for us. Further testing and consults with specialists in the weeks following revealed issues with my pregnancy so severe there was little chance I'd be able to carry to term. And if I did manage to give birth, there was no possibility my baby would survive. The news was shocking and heartbreaking for us. Abortion was the compassionate decision for myself, my family, and the child we'd hoped for. But even though we knew we were making the decision that was best for us, I had to endure needless barriers to care with very limited time left to surmount them. Among these barriers were the state-mandated 24-hour delay before I could get care and the required reading of biased information designed to shame and dissuade me from my decision. Since there were only 2 medical centers in the state that provided care at 23 weeks into a pregnancy, we were forced to make a 200-plus mile round trip to Ann Arbor, find child care for our then toddler, and coordinate overnight lodging. Because of state laws that prohibit public and private insurance from covering the cost of abortion care, and because I never would have expected needing a special rider from my private insurance, we were stuck with a hospital bill that topped $26,000. Although speaking with you today is way outside of my comfort zone, I feel compelled to do so because I am grateful every day for the compassionate and professional care I was ultimately able to receive. But I did not deserve the anti-abortion barriers we encountered and the additional distress we suffered. Not everyone is as fortunate as I am, and it is the most marginalized among us that suffer the greatest under these restrictive laws. When voters across Michigan overwhelmingly expressed support for legal abortion by voting for Proposal 3 last year, we sent a clear message to our elected leaders. Abortion access must be protected. That's why we need the Reproductive Health Act to ensure safe, legal, and compassionate abortion care is available to all those who need and want it. Thank you.
Thank you for your personal story. Representing the Committee to Protect Healthcare, we have Executive Director Dr. Rob Davidson joining us next to testify in support. Welcome and begin whenever you're ready.
Thank you, Chairwoman Rogers and members of the Health Policy Committee for the opportunity to speak in support of the Reproductive Health Act. My name is Rob Davidson. I'm an emergency physician who served my small rural community in West Michigan for more than 20 years. I'm also the Executive Director of the Committee to Protect Healthcare, a mobilization of physicians in Michigan and across the country advocating for pro-patient healthcare policies. Several of our members have provided written testimony today. They're all in clinic taking care of patients. Doctors were proud to help restore and protect personal freedom for our patients last year by supporting Proposal 3. Physicians believe, and Michiganders clearly agree, that decisions about abortion, just like every other aspect of healthcare, should be made between patients and their trusted doctors without political interference. That's why doctors have been frustrated for years by laws put on the books by anti-abortion politicians here in this state. These laws make it more difficult for doctors to practice medicine to the extent of their training and make it more difficult for patients to access the care they need and deserve. I want to be very clear. These laws are medically unnecessary, biased, and clearly politically motivated. And at the end of the day, they put many women in Michigan in tough spots. These barriers include rules that shut down clinics, forcing women to have to drive hundreds of miles to get care. As a rural physician, I know how difficult it is for many patients to access any health care, let alone health care that has been purposefully restricted. Other rules prevent insurance from covering abortion care, making it unaffordable for many women. And still others force women to delay care and receive medically inaccurate information prior to it. It's time for these barriers to go. All patients should be able to control their own bodies and access the care they need regardless of where they live, how much money they make, or what kind of insurance they have. All patients should be able to make their own decisions about their health care in private with their doctor without jumping through unnecessary hoops. Michigan doctors are thankful that Proposal 3 restored the right to abortion care and reproductive freedom, but we need to ensure now that patients have access to abortion care and reproductive freedom. That's why hundreds of doctors across Michigan and our committee are calling on our legislature to pass the Reproductive Health Act. Thank you.
Thank you for your testimony. To speak in opposition to the bills and testifying together, we will hear from Tom Hickson with the Michigan Catholic Conference, Eileen McNeil with Citizens for Traditional Values, Dr. Michelle Monticello, and Dr. Kathy Stark. I apologize. It will be Rebecca Masty, not Tom.
The red button.
Welcome and begin whenever you are ready.
Thank you. Good morning, Chair Rogers and other members of this committee. My name is Michelle Monticello, and I am a licensed board-certified obstetrician and gynecologist practicing in Central Michigan since 1995. Thank you for allowing me to speak to you today about the grave concerns I have about the Reproductive Health Care Act. I am here to represent myself and other physicians dedicated to providing safe, quality health care to women in our state. Since 1993, our state law has mandated informed consent for abortion procedures. The American College of Obstetricians and Gynecologists concurs with providing informed consent in their committee opinion number 439. Simply put, this requires that a woman is told in basic terms how the abortion procedure will be performed, the more common complications that can occur from the surgical procedure or from the medications used to complete an abortion, and what might be required to fix or correct those complications, as well as what may result in a permanent injury. It also may include what to expect afterwards and how to get help if she is experiencing problems. It is not overly burdensome for a physician or a physician's assistant to review this most basic information with a patient prior to their procedure. The Michigan Department of Health and Human Services even provides an online consent form that a patient can access, review, and sign 24 hours prior to her planned procedure. This waiting period allows her to consider the risks and ask additional questions if needed before proceeding. In 2013, additional protection was added for women that required asking questions to screen for coercion or force to have an abortion. This is considered a form of abuse. This helps to ensure that women are making these decisions for themselves. In my opinion, providing informed consent and protection against coercion are the minimum standards in providing women with good quality medical care. To do less is unethical. Women in the state of Michigan have a right to know this information in order to make medical decisions for themselves. To repeal these most basic protections in women's health care by taking away their right to know places their health and well-being at risk, which would be unjustifiable. I urge you to vote no on this current proposal. Thank you for your time.
Thank you, Chair Rogers, and the committee for the opportunity to express my opposition to this legislation you're considering today. My name is Dr. Catherine Stark. I'm a licensed physician and board-certified obstetrician gynecologist. I've practiced in Michigan for over 25 years. I've cared for thousands of women during my career, both in private group practice and at Beaumont Hospital in Southeast Michigan. I also hold an appointment as an adjunct assistant professor at Oakland University Medical School. I currently serve as medical director at Crossroads Care Center in Auburn Hills. I'm here today, though, representing myself and my patients. I'm grateful to address this committee today to express my concerns. This legislation seeks to reverse many common sense protections and safety measures that women in Michigan have actually benefited from for the past decade and more. Protecting the health and safety of women is not a partisan issue. It should not be a political issue. Abortion is legal in Michigan. It has been since I started my career in medicine. And it is still legal today. That's not the issue here. That women have the right to choose to abort or carry their child to term. That's not an issue here either. I think we should also all agree that we want women to make an informed decision freely, without coercion or deception. They should be provided with up-to-date and accurate information about any medical treatment or surgical procedure that they undergo. They should be confident in the quality of the care they receive. Women have a right to know. This act, however, includes a provision that would repeal the current requirement that surgical abortion facilities be licensed. As with all freestanding outpatient surgical facilities, this requires compliance with reasonable safety and cleanliness standards. This act also repeals the current requirement of reporting complications of abortion when they occur. As a physician caring for women, I have to wonder at the audacity to name this bill reproductive health. All of these measures you're trying to repeal were enacted for the protection of the health and safety of women undergoing abortion in our state. While these may inconvenience the abortion provider, they do serve a purpose in allowing the public to know when a clinic is not safe or a provider has repetitive violations of care. These requirements for licensing and reporting have not been undue burdens for my patients. If you were the patient or your daughter or your sister, wouldn't you want to know which abortion clinics have a high rate of complications? Or which clinic has had their license revoked due to dangerous practices? How could you know without reporting, licensing, and inspections? Why would you vote to end reporting requirements for surgical complications when all other surgical centers must report their complications? Please consider who's the beneficiary of such an unregulated industry. Women have a right to know, and women deserve better. Thank you.
Chair Rogers and members of the committee, thank you for this opportunity to testify today. I am Rebecca Masti with the Michigan Catholic Conference, and we oppose this package of bills. Well, there's a lot to be considered today. I wanted to take the opportunity to talk about some of the reasons for these laws. In particular, why the abortion clinic licensing law was put in place in 2013. For only 10 years now, it has been a common sense law that has helped to hold the abortion industry accountable to the women that they see. The law was necessary because prior to its enactment, abortion clinics in the state were operating with little or no accountability. At that time, only 4 of the 32 abortion clinics were licensed, leaving many having never been inspected. Of the 3 clinics that were inspected by the state from 2007 to 2009, serious violations were noted with equipment sterilization, maintenance of a sterile environment, and sterile pre-op hand washing. These violations were occurring at clinics that were being inspected. So what was occurring at those that had no state oversight, no licensing, and no inspections? The current law only requires abortion facilities that perform 120 or more surgical abortions a year to be licensed as a freestanding surgical outpatient facility. Surgical facility requirements for those performing surgical abortions. Seems to make sense. Here are a few of the freestanding surgical outpatient facility rules. Rule 325.45333 says that surgical procedures must be performed by licensed and credentialed health professionals. The next rule says a facility shall have a written policy and procedure to provide for adequate surgical hand scrub. The following rule requires surgical equipment to be stored in sanitary environments and maintained according to national infection protection and control guidelines. Should any woman seeking a surgical abortion be able to expect these standards are being met and verified by the state through inspection? For other supposedly cumbersome standards, on page 29 of House Bill 4950, at line 15, you'll see in the law being struck out that it allows the department to modify or waive one or more of the rules regarding construction or equipment standards if the department determines that the facility's existing conditions are adequate to preserve the health and safety of its patients and employees. Right before this law went into effect, an abortion clinic in Muskegon was shut down by the city fire marshal for its extremely unsanitary conditions. It was cited for having blood on the floors and walls, as well as for buckets containing unknown fluids being left uncovered in the operating room. It would be a detriment for the state to go back to situations like that being possible. Michigan women deserve the guarantee that any surgical abortion will only be conducted in a clean environment that meets basic health and safety standards. Please retain the law and oppose this package. Thank you.
Good morning, everyone. Thank you for the opportunity to provide testimony on the Reproductive Health Act. My name is Eileen McNeil with Citizens for Traditional Values, and I'm here to share my deep opposition to this 11-bill package that will, as you've heard from my colleagues here, strip long-standing common sense regulations and protections for women and children. But it also goes directly against the will of the voters of Michigan in several of these bills. I'm not a doctor, and I'm not a lawyer. I am a woman of deeply held faith. I represent, I believe, many, many, many thousands, if not hundreds of thousands of people across the state. And when the voters of Michigan approved the Reproductive Freedom Amendment, they did so with the understanding that Michigan laws would continue to protect their health as stated under Roe v. Wade. I refer you to the listed articles that I included in my testimony with repeated statements from the ACLU, Planned Parenthood, and the campaign that assured voters they would have the same protections and access to abortion as they had under Roe v. Wade. In November 3rd, the Detroit Free Press article, Darcy McConnell, the spokesperson for the Reproductive for Freedom for All campaign, stated, "Passing this amendment simply restores the same protections that Michiganders had for 5 decades under Roe v. Wade." Those are her words, not mine, not anyone else's. Those are the campaign's words to the voters of Michigan. Well, those protections are why we are here today. Why would you remove these protections? The protections included, you heard several of them, very important, the reporting, licensing, and inspection regulations. I've never heard of any medical scenario where people were repealing regulations. I've never heard of that before in my life. But it also does some other things. This package, as you know, it also bans horrific late-term abortions. It also makes sure that there is compassionate, humane disposal of fetal remains. I don't think anyone here would agree that the fetal remains from an abortion be disposed of compassionately. And it also respects the vote of almost 2 million Michiganders who voted to ban the funding for elective Medicaid abortions, elective abortions. Women can choose abortion, but Michigan residents, even those who support abortion, decided definitively that they shouldn't be compelled to pay for other people's elective abortions. This bill, this package would get rid of that summarily. Recent polling bears this out as well. I point you to the March 2023 poll done by the Marketing Resource Group that showed that 90% of Michiganders support keeping abortion clinic regulations in place. And of that 90%, 97% of those who were asked voted for Proposal 3. 63% of Michiganders support the 24-hour waiting period. 65% of those people asked voted for Proposal 3. In closing, I urge you to follow the will of the people of Michigan. I urge you not to bait and switch. Under the beguiling umbrella of access, this Reproductive Health Act recklessly endangers women, and I ask that you oppose this unnecessary, unhealthy, and unsafe legislation. Thank you very much.
Thank you. Next up, we have Genevieve Marnin with Right to Life of Michigan. Welcome to Health Policy. Begin whenever you're ready.
Thank you, Madam Chair, members of the committee, for giving me a few minutes to express my opposition to this Reproductive Health Act. My name is Genevieve Marnin. I am the Legislative Director for Right to Life of Michigan. I know others have addressed the health and safety concerns that this bill package raises, but I believe we can all agree that the well-being of women is paramount. Obviously, we hope that women will make a choice for life. But should she choose abortion, we believe she has the right to valuable information prior to making that abortion decision, as well as the right to a safe and sanitary clinic. No industry is left to regulate itself. Repealing these laws allows the abortion industry to operate without transparency, without oversight, and without having to follow the same rules as every other surgical provider in the state. Why would we have a carve-out for one industry at the expense of women's health? How does this serve women? Women have a right to accurate medical information, including the risks and alternatives akin to what's provided for any other medical procedure. The Informed Consent Law has been providing women with vital information about her abortion decision for 30 years. The State Informed Consent website was designed by DHHS in conjunction with medical professionals and provides women the option of viewing information from her computer or smartphone and satisfying the 24-hour waiting period without a trip to the clinic. We are told these bills are necessary to ensure access to abortion, yet abortions have increased every year for the past 7 years, despite these common sense laws being in place. And Michigan saw a 66% increase of out-of-state abortion patients this last year, which proves these laws do not prevent access. Prior to the 2012 clinic licensing law, some abortion clinics cut corners on safety, leading to horrific conditions like we saw in Muskegon and detailed by my colleague Rebecca. Removing clinic licensing laws puts profits over patient safety. Vital statistics are kept on all forms of medical procedures. Abortion supporters are now seeking to redefine abortion as a, quote, medical treatment, yet they don't want data collected like all other medical treatments. By eliminating abortion data, the public is kept in the dark about abortion complications, abortion tourism, and other demographic data. Transparency is fully removed from the abortion profession. I want you to think about the women in your life who may seek an abortion, your daughter, your friend, your sister, and ask yourself, will repealing legislation that regulates abortions make it safer or less safe for her to have an abortion? I urge you to vote no on the Reproductive Health Act. Thank you.
Thank you. All right, we are very tight on time. We are now going to have some time for representatives to ask questions. So far, I have Representative Reingans and Representative Vanderwall. If Representative Reingans would like to start.
Thanks, Madam Chair. I know you would like questions directed to you, and you're sitting behind me, so this is awkward. But Madam Chair, I'm curious about the difference between regular medically required informed consent that we get for every medical I guess, interaction. When we go to the doctor as patients, we have to have informed consent about what we're encountering as a patient. And so I'm curious why there's additional informed consent on top of what we already have to get as regular medical care. And I'm wondering if maybe Dr. Chrisman, maybe Dr.
Sure.
Rock,
Yep.
I don't know, since you deal with like a variety of care in a kind of more general practice setting too, might be able to help explain.
Thank you for your question,
Thank you.
Representative.
Thank you,
Representative. And would Dr. Chrisman like to answer that?
Sure, I'd be happy to answer. I think Dr. Lisa Harris was also still hoping to speak if possible.
Oops, you were on. Yep.
Thank you for the opportunity to answer that question. Informed consent is vital to all healthcare. We as healthcare providers are required when we recommend or discuss any treatment options, be it medicine or procedures, to discuss with patients the risks, benefits, alternatives, how the treatment impacts their unique patient situation. The requirement that is on the books related to the Michigan 24-hour abortion consent and informed consent law goes far above and beyond the requirement for all other healthcare and medical procedures. The regulation of healthcare, of which abortion is healthcare, remains intact with the RHA being passed. My professional and ethical obligations, my licensing requirements, my scope of practice are unchanged after the RHA. There is simply repeal of an overly burdensome, cumbersome, paternalistic requirement for a 24-hour consent form with pictures of fetuses, with a requirement that people view this information that is not tailored to them. It's not a discussion with their healthcare provider. It is printed information that doesn't meet the needs of our patients. As the brave person shared earlier about her experience having fetal anomalies and a highly desired pregnancy, can you imagine being then forced to look at pictures of fetuses and read information about parenting and adoption when that's not on the table for you? No, you should have that discussion with your healthcare provider about what your options are. And that stays in place with the 24-hour informed consent law being repealed.
Thank you very much. Minority Vice Chair Vanderwall.
Thank you, Madam Chair, and I just want to say thank you to everybody that's here in the audience today, those that are in overflow. I know there's a group of pharmacy students are here. I hope they're learning a lot today. I know they're in overflow, so I hope that you find these procedures informative and you have a great day here in Lansing. But as we heard testimony, and I believe a couple things that concern me is that over 5 years that I've been involved with health policy, we have strived to make sure that there's protections and there's policy put in place that all people are insured, that the facilities that they're at are licensed, the facilities that they're at are inspected, the facilities that are built to standards that if there is an emergency, a stretcher or a gurney can be brought in to make sure that that patient can be removed and brought to a hospital for further observation or extended. As I read 4950, this eliminates a lot of those procedures that are put in place, and I guess I'd love to understand the bill sponsors' reasoning why that we would reduce standards instead of continuing to make sure that Michigan Health and what these bills are put forth is that we're going to make sure and ensure that they have good health. My question is, why would we remove these things, and what what does this prove to a patient that they can feel safe when they go to a facility?
Thank you. So to speak to House Bill 4950 is going to be Representative Pahutsky as well as Dr. Chrisman again.
Thank you, Representative, for your question. The fact of the matter is there would still be regulations in place. There would still be licensure requirements. There would still be scope of practice. All of that is retained. What is changing, and I asked Dr. Chrisman to come up because she is the medical professional, not me, which is part of the problem here. Those requirements that you outlined are for a facility that performs procedures that are not performed at a facility that provides abortion. So I would like Dr. Chrisman to explain some of that, but there are not surgeries performed at abortion provider. That abortion providers do not perform surgeries. None of those requirements actually make abortion procedures any safer. And I would really like the doctor to elaborate on that because she performs abortion.
If I can just direct a quick question to you then. I guess that confuses me, and I hope, Doctor, you can explain that. I mean, we currently, right now, inside a dental facility that cleans teeth, we make sure they're licensed and have oversight. So I guess anytime that you're doing anything with the human body, that's called surgery to me. So I hope that you have a good explanation. Thank you.
So there is a difference between procedures and surgeries. So there are many clinics that perform biopsies, that perform skin procedures, dental procedures that are office-based settings, that are clinical settings. Obviously, there are surgeries where we make incisions on people's abdomens or other parts of their body that require a surgical facility. Abortion procedures are not that type of procedure. As I said in my earlier testimony, in 2018, the National Academies of Sciences, Engineering, and Medicine published a report on this exact issue. And they concluded that there is no evidence that performing aspiration abortions or abortion procedures in ambulatory surgical centers is necessary. It does not increase the safety or efficacy of the procedure. Just because a healthcare facility is not an ambulatory surgical center doesn't mean that it doesn't need to meet cleanliness standards, that the staff don't have to be licensed or trained, or that there's no regulation. It simply means that abortion care does not need to take place in an ambulatory surgical center. We're talking about regulations that include factors like the ceiling height and the bathroom size. These type of regulations have made it impossible to expand access to abortion care in the northern, more rural areas of the state because of the incredible burden that it places on a facility that's offering an office-based procedure. And I'll just give one other example. Aspiration abortion care or procedural abortion care is the same care we provide for miscarriage. It's exactly the same procedure. And we do miscarriage care in the office. It allows patients to be cared for by the healthcare provider in their community without having to travel. And it's literally the same procedure.
Thank you. We do have several questions.
Sure. One last statement, and I appreciate what you're saying, but I'm looking at here right now, the AMA adopts the following definition of surgery. It says surgery is performed for the purpose of structurally altering the human body by incision or destruction of tissue and is part of the practice of medicine. So I'm just getting to the point. I understand what you're trying to make public here, but what this is, it is surgery. We are going in and altering a human body. And what my concern is we remove licensure and inspections. We aren't performing what we sit here as a group And we're trying to make sure that what we do here in the state of Michigan, make sure that all patients, and in this subject, it's of course a little difficult, but what I'm saying is that it is surgery, and when we remove licensure and inspections, we are not caring for all people the same, and it disappoints me.
Just to be really clear, because many people don't understand how abortion care happens, there are no incisions made in abortion care. We are not making any incisions. The uterus has a natural opening, the cervix. When you read that statement about surgery and procedures, that would imply that an incision meant to remove a spot on my arm that needs to be biopsied, that must also be surgery. And thus my primary care doctor's office would need to be an ambulatory surgical center. And I think we can all agree that that doesn't make sense. So I think we should leave it to the data, to the National Academy of Sciences and Engineering and Medicine that convened a report on this, to the medical experts who are telling you we literally do this exact same procedure for miscarriage care, and that it's really safe. It doesn't require an ambulatory surgical setting to be done safely.
Thank you so much. I'm going to move along so that we can get a couple more questions in. Representative Roth.
Thank you. Thank you for the testimony of everybody today. I appreciate it. You just mentioned data and healthcare. I understand some of these bills are going to remove some of the reporting. How do we do that in the state of Michigan and not understand what goes on? If the clinics are 100% great, let's have that data. Let's put it out that it's 100% great. So I just have a very big problem. We track all kinds of surgeries and medical procedures throughout the state. And to remove that, I think, is a detriment to both.
Thank you again for that great question. I want to again emphasize these are removing bills that treat abortion differently than other healthcare. Abortion reporting requirements silo, scrutinize, and stigmatize abortion care uniquely and unnecessarily. Moreover, they attach penalties that criminalize providers if they fail to report that basic provision of healthcare within 7 days. We saw this just this past year in our neighboring state of Indiana, where the Attorney General launched an unfounded attack on Dr. Caitlin Bernard based on their state's reporting requirements, which she was found to have followed. The abortion reporting laws were used in an attempt to undermine her credibility and her care. Mortality rates are higher for colonoscopies and adult tonsillectomies, as I said earlier. Yet there are not specific laws on the books that say if you don't report a complication from your tonsillectomy in 7 days, you as a healthcare provider are a criminal. This is treating abortion as something other than healthcare. Abortion is healthcare.
Thank you. Moving along, I've got Representative Hosma and Representative Thompson, and I want to leave some room to read in cards, which is going to take a minute. Representative Hosma.
Thank you, Chair Rogers. Is Dr. Davidson yet here?
Yes.
Could I ask you a question if you
Come
could
on
come
up,
forward?
please.
Yeah. Dr. Davidson, during Ms. Martin's testimony, she indicated that there is valuable information, as she depicted it, afforded a patient in this 24 hours period before a procedure. You indicated in your testimony that this information is in some way medically inconsistent or medically apocryphal or wrong. Could you explain what is there which is not consistent with medical evidence that's sometimes provided in these 24-hour opportunities to have, quote, valuable information, end quote?
Sure. I think, as has been stated by abortion providers and by our patient example here, I'm sorry, I forgot the woman's name. That's a one-size-fit-all bit of information that is provided to all patients. When you have patients who have unviable pregnancies, who have wanted pregnancies, or who have pregnancies that endanger their life, but they are essentially choosing abortion as a healthcare option to either provide for their life or to prevent their own suffering with carrying a pregnancy to term that cannot survive. And they're provided with pictures of developed fetuses, of information on parenting, as has been stated. This can be severely traumatic and has no bearing on anything to do with the procedure that they're about to undergo. I do invasive procedures on patients all the time. In 25 years of practice as an emergency physician, I reserve the right to talk to them about that time I'm doing a spinal puncture or doing an intubation or putting a tube in their chest. And I don't really think that the state of Michigan, the government or politicians should be creating a one-size-fits-all document for those patients. It should be the same with abortion. That is health care as every other bit of health care.
Thank you. And Madam Chair, I have a question for Dr. Monticello, if she's still in the room. Dr. Monticello, I'm curious about your response. Representative Reingen's question earlier answered by Dr. Chrisman. I'm curious how you would respond to a similar question, which is, are there other procedures other than abortion procedures, stents, placement in coronary arteries, lung transplantation, cataract removal and replacement? Are there other procedures which mandate a 24 hours disclosure and cooling off period, for lack of a better depiction?
To my knowledge, no. But what I feel is...
Thank you. You've answered the question. Appreciate it.
Thank you, Madam Chair.
To finish out testimony on these bills, we will hear from Dr. Lisa Harris with the University of Michigan. Dr. Harris, if you can share your perspective as a professor, medical doctor, and researcher in the healthcare space with a focus on clinical obstetrics and gynecological care. Welcome. And that will be our final one, and then I will read in the cards.
Thank you. Thank you so much for the opportunity to be here today. As you heard, I'm Dr. Lisa Harris, and for over 25 years, I've been an obstetrician gynecologist at University of Michigan, though I'm here today in my individual capacity. I became an OBGYN to be a source of compassion and expertise for patients and their families as they navigate reproductive experiences, including birth, miscarriage, and abortion. I've included abortion care in my work because I want to be someone my patients can turn to and know that they will not be abandoned and they will not be judged. I did not go into medicine to be part of political debates. However, I am here today because it is important that laws center the needs of people they most affect, namely my patients. Some of you, and perhaps the Michiganders you represent, may feel internal conflict about abortion. Indeed, many people see its complexities and carry two opposite ideas in their or perhaps your hearts at the same time. Abortion means a future human will not be born, and that is weighty. And lack of access to abortion care means women may not be able to determine the course of their lives and their health and their families' lives, and that is also weighty. Both things are true, and that is what makes abortion a hard issue. It makes sense, then, to feel reassured by laws restricting abortion because they provide a sense of medical and moral guardrails. The experiences of my patients show me, though, that our current laws under reconsideration today function not as guardrails leading to ideal care, but as impediments to ideal care, as you've been hearing. And I'll focus as an example on our 24-hour consent requirement. And as you well know, patients seeking abortion care must view state materials at least 24 hours before. And as you heard, if viewed online, they must print a time and date stamped confirmation page which expires in 14 days. Or they can pick up materials in person. Both are difficult for many patients and in practice delay care beyond the 24 hours that the legislature intended. Most people can't come in person on an additional day due to childcare and work needs, already struggling to manage those commitments for the abortion appointment itself. In Michigan, almost 70% of women who end a pregnancy are already mothers. Many patients put jobs in jeopardy by taking a day off for care, and an additional day prior is not possible. The online option, as you heard, does not eliminate complications. Some patients don't have internet access, and even more have no printer. Abortion stigma means that using a friend or family member's computer or a public library computer is not feasible. Last month, I had a patient and her partner use their very limited resources to try and buy a printer to fulfill this requirement. Many find the online process confusing and not uncommonly print the wrong page without the time and date stamp, or they forget the form at home, which may be a day's drive away given limited care facilities in our state. Some people, as you heard, don't know about the requirement, and without the printed confirmation page, we of course cannot and do not proceed. Postponing care is not as simple as it might seem. It requires, again, juggling childcare, work, travel, and appointment availability, and therefore care commonly gets delayed for days and even weeks, leading to an abortion later than a patient intended. This carries more risks than earlier in pregnancy, though abortion remains, according to CDC data, 50 to 130 times safer than term childbirth. Sometimes people have the correct paperwork, but we discover health issues that need to be evaluated and treated before we can safely proceed. This is especially true in the hospital setting, in which I see the most medically complex patients. Or a patient, after our conversation, may decide they want to consult with a high-risk obstetrician or their clergy. If they return after the 14-day expiration of their paperwork, once again, we cannot proceed and care is further delayed. And what I've described are not hypotheticals, but happen every single day that I see patients. The state-mandated process, importantly, duplicates what care teams always already do: ensure patients have the time and information they need. And I'm well aware that the negative stereotypes of doctors who provide abortion care make it hard to see that we're motivated by compassion, by conscience, by safety, and most of all by our patients' needs. There is no one who wants a patient to make the right care decision for themselves more than those like me responsible for providing that care. I will never, never proceed if a patient is unsure or unaware that their abortion is only one of the possible paths ahead, paths that include adoption and parenting. Medical ethics already requires that we ensure patients understand their care, including its risks and alternatives. Put another way, guardrails already exist in our training, our education, licensing requirements, continuing education requirements, and scope of practice constraints, as well as medical ethics and the laws and policies that already govern all medical care. If I can take about 1 more minute, I just want to finally say a word about insurance restrictions and their impact on patients. As you know, current Michigan law restricts public and private insurance coverage for abortion, and this again delays cares as patients work to find funds to support their decision to end a pregnancy. Half of people who end a pregnancy live under the federal poverty level, and another 25% on just 1 to 2 times that. Economic insecurity is among the top reasons cited for ending a pregnancy. And therefore, it's paradoxical that the insurance relied upon by the people with the fewest resources would not include routine coverage for abortion care. Some patients need hospital-level care due to underlying health conditions, and without insurance coverage, as you heard already today, for most, it is completely out of reach. And faced with this, I've had patients frighteningly say they will seek outpatient care elsewhere and not disclose their underlying health condition, a dangerous consequence of insurance restrictions. Others must continue their pregnancy, and research tells us that lack of Medicaid abortion coverage is associated with more births to young girls, more preterm birth, and other adverse outcomes for women and their children. I know Michiganders across the political spectrum to be compassionate and practical.
Thank you, Dr. Harris. If you can wrap up the last sentence.
And while many would never choose abortion for themselves, they would want someone else to make this decision to be cared for in the most timely and safe ways, which our laws impede. I'm here only for our patients, the patients I see. I am not the one most burdened by the laws under consideration today, and indeed when patients are turned away because their paperwork's not in order or they don't have a way to pay for care, I get home to my own children and family sooner.
Thank you, Dr. Harris. Unfortunately, we are out of time. I wanted to quickly read as fast as I can because we have session at noon, and I'm sorry that we did not get to everyone who wished to testify. In support of HB 4949 through 4959, we've got Lindsay Moss, Denzel McCampbell, Yusuf Rabi from Michigan Nurses Association, Michigan Council of Maternal Health, Michigan Academy of Family Physicians, Gianna Yu, Dr. Brittany Lett, Michigan League for Public Policy, Progressive Democratic Women's Caucus of Muskegon, Andrew Chichtel, Emily Clancy, Barbara Reinhold, with Fountain Street Church Choice and NARAL, Residents Supporting Health Care for All, Planned Parenthood Advocates of Michigan has multiple, PPGA, MOASH, Michigan Voices, Amy Belfer, Planned Parenthood of Michigan, Chasha Johnson, Cynthia Gutierrez, Michigan Chamber FRRS, ACLU of Michigan, Dr. Sua Syed, another Planned Parenthood, YWCA of Kalamazoo, Margaret Stepfoot, United Church of Christ, MCRL, and Michigan Coalition for Reproduction. Opposing, Robert Brines, Janice Brines, Donna Gratson, Tony Gratson, Libby Ponshaw, Catherine Bassard, sorry, these are all in opposition, Catherine Bassard, Austin Kreutz, Jan Richtenwald, Sandy Westerby, Ed Rivet, Joanne Still, Representative Joe Fox, Mitch Dobrolowski, Mark LaForet, Kim LaForet, Vivian Liptel, Christine Bodwell, Jennifer Abbott, Protect Life MSU, Protect Life MSU, Protect Life MSU, Trevor Paulo or Dallo, Adelaide Helwig, Haley Gusa, Cassidy Schultz, Kristen Paulo, Professor William Wagner, God's Truth About Life, Jan Gilles, Joseph Tusky, and Rick Renshaw. And it is my intention to bring up these bills very soon for a vote in the near future. Keep an eye on your email inboxes for a meeting notice. There being no objection, we will stand adjourned. There being no objection, motion prevailed. And there being no further business before the committee will stand adjourned.